No, Sheila, you need to unmute yourself.
Hi, everybody, and a very, very good afternoon to each and every one of you out there who have once again spared their precious time to spend a fantastic Sunday evening with us out here. And believe me, it is worth every minute that you spend with us over here, because we are today welcoming you to the third module of interdisciplinary endocrinology, where the theme, as we all know, is pulmocrinology. And we have none other than the great Dr. Jindal. We all know Sir. I mean, we all know Sir as not only as a professor of medicine, but we all know Sir as a great teacher. So much to learn from him, an absolute icon, number of awards. If I start listing those awards, it will be 5 p.m. and I can't afford to do that. So I am going to hand it over to Sir to take the proceedings forward from here, for us to be able to understand better what would the endocrine manifestations of tuberculosis be, and how do we manage these patients, how do we diagnose them, and of course, how do we treat them better. Thank you very much. Over to you, Sir. Sir, you are muted, please.
Thank you. Can you hear me now?
Yes.
Okay, thank you very much for your very kind words. In fact, the pleasure is entirely mine. Good evening, every participant. I'm sure this program will be useful for all of you. I think it is a very good initiative of the Endocrine Society, in particular with the efforts of Dr. Sanjay Kalra, Dr. Saptarshi, and other team. I may not know actually the people who are working hard behind this activity, but certainly I must appreciate the great effort which you all have put in. You see, the program include, of course, I'm just to kind of put in some words here and there. Perhaps you see, we'll be keen to learn from the quiz and the talk by Dr. Pramila, and the quiz to begin with by Dr. Chitra Selvan. I think we can straight go ahead with the quiz now, and thereafter we'll have the rest of the agenda. Thank you.
Thank you, Professor Jindal. Thank you for being with us, and thank you for that introduction. Thank you, Dr. Shaila, Dr. Saptarshi, for the opportunity, and the Endocrine Society of India for continuing to find new ways to engage with our audience in these difficult times. And I welcome the audience to participate freely in this quiz on the topic of endocrine manifestations of tuberculosis. There will be, I'm Dr. Chitra Selvan from Bangalore. There will be 10 questions. Make sure you type all the answers together and send them at once in the chat box. Make sure you identify yourself as well. We're going to pause for about 1 minute per question. The entries will be open for another 5 minutes at the end of the 10 questions. The results will be announced at the end of the program, after the talk, after the deliberation following the talk. And there are 3 prizes to be given away by Dr. Saptarshi Bhattachi. He has not yet revealed what the prizes are, but I'm sure they're very well worth it. So with that in mind, get set and let's go. So the first question, there's a 46-year-old male who's been diagnosed with biliary tuberculosis and started on anti-tubercular medications and discharged home. Since the last 5 days, he's been having complaints of feeling giddy, feeling low. He's brought to the emergency room on the 5th day with altered sensorium. And on examination, his pulse rate is high, his blood pressure 86/50 millimeters of mercury, and he has cold and clammy hands. The investigations reveal a creatinine of 1.4 milligrams per deciliter, a sodium of 122, and a potassium of 5.6. There are 3 parts to this question. What is the one test that you will ask for? What treatment would you administer? What is the diagnosis you're thinking of for this particular ER visit? And what is the mechanism behind it? The 3 parts to the question. Make sure we answer all of them. moving on to the next question. In individuals who have tubercular meningitis, the most common abnormality noted related to the pituitary are central hypothyroidism, diabetes insipidus, hyperprolactinemia, relative or absolute cortisol deficiency. This is specifically in individuals with tubercular meningitis. The most common abnormality reported is central hypothyroidism, B, diabetes insipidus, C, hyperprolactinemia, D, relative or absolute cortisol deficiency. Moving to the next question. This is an imaging question. What is the finding that you see in this image? Please note that there are two arrow marks pointing. First, identify the finding. Second question, give two differentials for the same. Next question. This is a pop culture question. This is a person whom we lost to tuberculosis and the endocrine condition associated with it. But she probably described the trouble of living with this condition in one of her numerous letters to her sister. She's written numerous novels. Her most popular ones are Pride and Prejudice, Emma, Sense and Sensibility. My question is, far away from medicine, identify the author. We celebrated 200 years of her birth very recently. Identify the author. Next question. We have a 32-year-old lady who's been on anti-tubercular medications for pulmonary tuberculosis for the last 2 months, and she's come in for her review. She reports that she's been noticed menorrhagia, which is of recent onset, along with which she also gives complaints of pain and cramps and overall body ache, more commonly in the shoulders, arms, and thighs. Her appetite is good, she's gaining weight, and there is no other complaints apart from these two symptoms. On examination, most findings are normal. The investigations that she came in with, which is a complete hemogram, liver function test, and renal function test, are all normal. An ultrasound pelvis is also normal. What other test would you need to think of to identify the reason behind her current complaints? Would you want to ask for a TSH, 2, 8 AM cortisol, 3, follicle stimulating hormone, 4, anti-Mullerian hormone? This is question 5. Question number 6. Hyponatremia in an individual with tuberculosis could be due to all of these reasons, except the reasons are adrenal insufficiency, hypopituitarism, syndrome of inappropriate secretion of antidiuretic hormone, cerebral salt wasting, diabetes insipidus. You'll need to choose one answer. Hyponatremia in a person with tuberculosis could be due to all of these except. Question number 7, hypercalcemia in tuberculosis. All of the following statements are true except. It is usually mild and it does not correlate with the severity of illness. The hypercalcemia usually resolves spontaneously within 1 to 7 months of initiating anti-tubercular treatment. The hypercalcemia in tuberculosis is due to secondary hyperparathyroidism due to coexisting vitamin D deficiency. The hypercalcemia is due to increased 1-alpha hydroxylase activity in the macrophages. You will need to choose the one statement which is incorrect. Question 8. This is a published case report of a young lady who walks in with complaints of weight loss and malaise and tiredness. And this is the examination finding. What is the diagnosis you're thinking of? And what is the treatment recommended? Please make sure you're answering both parts of this question. Question 9, again, a pop culture question. This is a poet whom we lost at a very young age, at the age of 25 years. He was a prolific writer. And in one of his works, which is the Ode to a Nightingale, we find one of the most detailed descriptions of tuberculosis itself, very vividly described tuberculosis itself. He and his entire family were afflicted. Identify the poet. The clues are the work that he published, which is Ode to a Nightingale, and the era that he wrote it in, which is in 1819. And the last question. In 2015, the declaration was signed at Bali, Indonesia, to target curtailing tuberculosis with another common endocrine condition, both of which make a deadly duo. This agreement is talking about which endocrine condition? That's question part 1 of this. And the second part of the question is to at least list one key point that was spoken about in this declaration to tackle tuberculosis and this endocrine condition. That's the end of the 10 questions. The entry in the chat box will be open for another 5 minutes. Kindly send in your answers. The results will be announced in the end. May I now request Dr. Jindal to kindly take over?
I think Jindal sir has got logged off, Mintu.
Yes, ma'am.
I think till Jindal sir logs in again, Pramila, maybe we can start with your talk. And then
Sure.
once Jindal sir joins in again, we could hand over the proceedings to him.
Sure. So good evening, everyone. And it's an honor to speak in a session where Dr. Jindal is a chairperson. And at the outset, I thank the Endocrine Society of India for inviting me for this talk, and especially Dr. Saptarishi and Dr. Shaila. And thanks, Dr. Chitra, for the quiz questions. So I'll be talking in the next half an hour about endocrinological manifestations of tuberculosis. Now, this is a very interesting topic because even when I was reading yesterday more and more about it in the past 1 month, whatever I've read, what I've realized that there are many, many things which we still don't even always think of when a patient comes to us in the OPD. So if you see this World Health Organization data as of 2018 for India, it's around 450,000 TB deaths have happened in that year, and around 2,690,000 patients fell ill with tuberculosis. And if you see, the treatment success rate was 81%, and the target for 2022 is 90%. And treatment coverage, if you see, is 74%. So it's quite unfortunate that still in our country, a lot of people still don't have the treatment or they don't take the treatment properly. And we all know that there are a lot of defaulters still. And that's why a lot of multi-drug resistant and other tuberculosis is still there. And if you see the number of the TB cases which were attributable to 5 risk factors, obviously undernourishment is the most common, but diabetes also is one of the things which we need to know about, and alcohol, smoking, and HIV are always there. Now, when we talk about tuberculosis in endocrinology, now this is a great mimicker because it can affect actually almost any organ in the human body, and we can have varied presentations. It can affect the adrenal, pituitary, thyroid, pancreas, lead to calcium disorders, gonadal dysfunction, glucose abnormalities. So all have been documented. Some have been documented as case series, some are case reports, some are common, some are uncommon. Now, first, let's talk about adrenal. I think all of you must have seen this picture in Chitra's quiz, so we'll know the answer at the end. So we know that adrenal and tuberculosis is still a common cause of adrenal problem in developing countries, especially the places where the TB prevalence is high. It may manifest years later after the disease, or maybe the sole manifestation. This is very important because it's not necessary that the patient at the time of presentation will have overt tubercular manifestations. They might have got it long time back. They might manifest only as adrenal problem. And along with that, the most common extra adrenal places where we see it is the pulmonary and the genitourinary tuberculosis if a patient has adrenal tuberculosis. Now, both adrenal glands are usually involved, but they may not be equally affected. That's why you would see in some patients, they may be deficient in cortisol, but they may be partially deficient. Some patients may require mineralocorticoids, some patients may not require, because there may be a differential involvement of the adrenal gland, and especially also that both sides may be unequally involved. Now, if you see the clinical presentation, these patients may present or may not have a history of tuberculosis because, as I said, sometimes it may not be manifest. They may have active disease. They may have a positive tuberculin skin test. They will normally present with the classical manifestations, either some disease or some stressor or some sickness would precipitate it, or they may directly come like that. And they may get an adrenal insufficiency or adrenal crisis, and they may even come to the emergency. They may have malaise, anorexia, orthostatic hypotension, and hyperpigmentation as well. Sometimes these patients just come with vague fatigue, hyperpigmentation, weight loss, diarrhea. Now, if you see the mechanisms, it can be either the direct destructive effect on the adrenals, increased levels of pro-inflammatory cytokines like TNF-alpha, which inhibit the adrenal cortisol synthesis, anti-tubercular drugs like rifampicin, which induce the metabolism of cortisol. That's why it's very important that when a patient is started on anti-tubercular treatment, you would like to do a ATM cortisol to see if the patient has borderline cortisol deficiency and maybe a stimulated cortisol as well if you have the doubt of diagnosis, because patient can go into crisis once we start rifampicin if they have borderline adrenal insufficiency, which is already there. So we need to be also sure that these patients may have also concomitant infections when they get tuberculosis. Some of them may have coexistent adrenal infiltration by HIV as well. And they may have some neoplasms like Kaposi's and lymphoma as well, which can be commonly seen with HIV infection. So subclinical adrenal insufficiency is very common. So in one of the studies, they found that it was around 23% when they tried to check with a low dose of 1 microgram of synactin. So it's very important, especially in the patients when we are going to start the drugs, that is the anti-tubercular treatment, especially rifampicin, which can precipitate a crisis. So if you see the imaging in these cases, the most common findings, you will see a non-calcified enlarged adrenal gland with areas of lucency and caseous necrosis. And there may be a peripheral rim enhancement following the contrast administration. But when you see a chronic patient, then the adrenal glands may be shrunken and they may have calcification, they may have irregular margins. MRI can also be done, which may show hypointense or isointense areas on T1 and hyperintense areas on T2 weighted images. In one of the large autopsy series, they found that 6% of the patients with active tuberculosis had actually evidence of adrenal infection. And in 1/4 of these patients, actually the infection was isolated to the adrenal glands. Some people and some series have found lesser as well, like 3%. Now, this is how a normal adrenal will look like, and this is how a chronic TB adrenal will look like on autopsy studies. And this is the calcification we can see in long and caseous necrosis, which can happen in long-standing tuberculosis. Now, interesting is all these patients may not have recovery of adrenal function after the treatment with anti-tubercular treatment. So some studies have shown that there may be recovery if the patients are caught early within the first 2 years where the adrenal is still recovery is possible, where the treatment works and they may recover. But there may be lack of recovery over a period of time, especially where the chronic changes have already happened, calcification has already been there. Those patients may not recover and may continue to require cortisol supplementation. Now, coming to a very, very interesting topic of diabetes. All of us love this topic, that tuberculosis and diabetes. We know that prevalence of tuberculosis among diabetes patients is quite high. It's 2 to 5 times higher. This is very well known. And there may be lots of reasons for that, like abnormalities of the immune cell function, impaired cytokine production, pulmonary microangiopathy, effects of non-enzymatic protein glycation on the alveolar membrane and the pulmonary basal lamina. Now, these diabetic patients definitely have the tendency to develop tuberculosis more commonly. And also, the other vice versa is also true. Like chronic infections like tuberculosis can cause stress or reactionary hyperglycemia because of increased production of counter-regulatory stress hormones like epinephrine, glucagon, cortisol, and growth hormone, and which can further cause further hyperglycemia. And very, very interesting that tuberculosis can also affect the pancreas directly. And it can actually mimic a pancreatic carcinoma. There are some case reports in world literature where a patient was operated as a case of CA pancreas, but on histopathology, they found that it was actually a tubercular involvement of the pancreas. And in abdominal tuberculosis, ileocecal region is the most commonly affected, but there can be other organs, and also pancreas involvement can be rarely seen. It's not very common. This was a case where it was thought of as a CA head pancreas. Patient was operated, Whipple's procedure was done, and later the histopathology actually showed that it was a tubercular lesion. So this is how we should suspect any patient who comes like that. That doesn't mean that every patient of pancreatic CA we start suspecting tuberculosis, but could be one of the rare differential diagnoses because still it's quite common in our country. And also, interestingly, it has been seen that treatment of tuberculosis can lead to diabetes resolution because there will be reduction of the inflammatory cytokines. In this one of the studies, they showed that there was a documented decrease in the crude diabetes prevalence rate from 6.5 to 4% after the patients were treated for tuberculosis. Now, coming to another interesting topic in tuberculosis, that is calcium and tuberculosis. Now, rarely tuberculosis can involve the parathyroid glands through hematogenous spread, or it can be from an adjacent affected structure like thyroid. Hyperplasia may happen, and these patients can present like primary hyperpara, but these are not very common presentations. Patients with Addison's itself can present as hypercalcemia, but this could be because of the direct effect of the tuberculosis bacteria or the tubercular bacteria on the parathyroid gland. And if we see that patients who have hypercalcemia, they may also have extensive pulmonary involvement, and very commonly, but not commonly overall, but because if hypercalcemia happens in tubercular patients, there can also be increased levels of 125 dihydroxy vitamin D in these patients. Also, there can be other reasons which are very, very rare. Like I said, adrenal insufficiency can present as hypercalcemia. Now, hypercalcemia in tubercular granulomas can happen because of the increased 1-alpha hydroxylase, which is expressed in the activated macrophages, which leads to conversion of 25-hydroxyvitamin D to 125-dihydroxyvitamin D or calcitriol. And in one of the studies done in Nigeria, they found that the prevalence of hypercalcemia among 120 newly diagnosed TB patients was very high. That was around 27.5. So it may vary according to region. And it is less frequently noted in conjunction with the extrapulmonary disease, including miliary infection, peritonitis, and osteomyelitis as well. And it's very important that hypercalcemia may not be noted at the time of diagnosis, but it is seen early in the course of treatment. Now, a region just connected to the parathyroid, that is the thyroid. Now, thyroid is uncommonly affected with tuberculosis, reason being presence of colloid, high blood flow with excess bactericidal iodine, increased phagocytosis, which is associated with hyperthyroidism, and extensive lymphatic and vascular supply to the thyroid. So all these have been postulated as mechanisms because of which the thyroid is uncommonly affected. Tuberculosis has been seen only in about 0.1 to 1% of patients with thyroid when the thyroid tissue has been sampled for any indication. So it can result from hematogenous dissemination or by direct extension from an active lymph node, which is in that area. So primary thyroid tuberculosis in the absence of involvement of any other organ, it's very, very rare. So it can have 5 varied presentations, ranging from a solitary cold abscess to a diffuse goiter, which can have caseation. Acute abscess can be one of the presentation. We had one patient like that. Multiple lesions from miliary spread and chronic fibrosing tuberculosis. So miliary spread actually is the most common way of presentation with multiple cold abscesses, which mimic the presentation of a thyroid CA. And if you see thyroiditis, it is less commonly seen, but if a patient has tuberculous thyroiditis, they are less likely to note the pain, thyroid tenderness, and fever, and duration of symptoms actually tend to be greater in patients with tuberculosis. And thyroid function tests, initially these patients can manifest because of thyroiditis as thyrotoxicosis due to the rapid release of the thyroid hormones. And over a period of time, there may be destruction of the thyroid gland and they may manifest as hypothyroidism. Sick euthyroid syndrome can be seen in many of the acutely ill tubercular patients. And this is one of the most common thyroid abnormality or in the biochemical testing, which is seen in these patients. And it has been reported to be around 46 to 92% in various studies in patients who present with a diagnosis of tuberculosis. Now, imaging, if we do in such cases, it may range from a solid and a heterogeneous mass to a cystic or a hypoechoic lesion. And radionuclide scanning will show a reduced uptake in the affected tissue because it's an inflammatory involvement. Now, pituitary and hypothalamus can also be affected because of the hematogenous spread. It can be either be associated with miliary disease or it may be because of just the direct spread. They mostly have an indolent presentation. They may present with headache, visual complaints, or they may present with abnormalities of the growth hormone, hypogonadism, hyperprolactinemia. They can present as granulomas. They can present as diabetes insipidus. Rarely, we may see even pan-hypopituitarism also. And in the diagnosis, histopathology is the definitive diagnosis where caseating granulomas, even if we document the organism, the best thing, but we may not be able to see it always. And on a CT or MRI, it will look like a tumor and angiography results will be normal. And even secondary to tuberculous meningitis, people have seen pan-hypopituitarism also as one of the manifestations, but it is very, very rare. Sometimes rarely thickening of the pituitary stalk can be seen in these patients. And in one of the older studies, way back in 1941, they found that the pituitary involvement was quite rare. Anterior pituitary involvement was quite rare. Hyponatremia, also seen as one of the manifestations of tuberculosis. They can be because of adrenal insufficiency, SIAD. It can be also because of cerebral salt wasting. Hypoxemia, which is associated with pulmonary tuberculosis, actually can stimulate the baroreceptors, which can lead to AVP release from the posterior pituitary. And also there can be sometimes ectopic production from the lungs also in these patients. And there can be sometimes the resetting of the osmostat. So if you see the effect of tuberculosis on the circulating hormones, this could be mediated through malnutrition, altered peripheral metabolism of the hormones, effects of the cytokines, inflammatory mediators, and also effects on the gonadal hormones like low testosterone happening in males, inflammatory cytokines release, increased cortisol. If the adrenal is normal, then there can be increased cortisol levels as well. There can be decreased secretion of gonadotropins. So if you see in a male tubercular patient, they can present with increased prolactin, decreased testo levels. Thyroid hormones may be increased initially because of toxicosis. They may have increased E2 levels, DHEA may be reduced. If the adrenal is normal, not affected, they may have increased cortisol levels. Interleukin-6 may be high, interferon gamma and other inflammatory markers may be high. They may have a reduced leptin and the BMI may go down. Thymic tuberculosis, very, very rare entity. So if you see in a patient with tuberculosis, the involvement of the thymus, there can be some involution of the thymus because of the low testosterone, increase in the thyroid hormones, increase in the prolactin. There can be an increase in the growth hormone, but there won't be an increase in the IGF-1. Even in spite of the growth hormone increase, the IGF-1 levels remain normal. And the glucocorticoids may be more. The inflammatory markers, interleukin-6, interleukin-1 beta, all that may be increased. The DHEA may be reduced. Other abnormalities are seen with result of therapy. So anti-tubercular therapy can cause an increase in the TBG levels. If you see early in the illness, the IGF, that is the insulin-like growth factor levels may be reduced. Some patients may have initial rise of the growth hormone, but in chronic illness, growth hormone levels may be reduced. Prolactin levels may be elevated because of the stress, that is the physical as well as the psychological stress. Important to understand that anti-tubercular treatment itself can lead to some changes in the hormones or the metabolic levels. We know that intensive phase has 4 drugs, continuation has 2 drugs in a new TB case. But if a patient has a complicated tuberculosis like CNS or pericarditis or musculoskeletal or miliary, they may need the continuation phase with 7 to 10 months of 3-drug therapy. So rifampicin is a potent inducer of P450 hepatic microsomal enzyme. So patients who are having adrenal insufficiency or borderline levels may need an escalation of the cortisol dose because these patients may land up with crisis. Rifampicin increases the catabolism of vitamin D to inactive metabolites. It also can increase the insulin requirements in type 1. This has been postulated because of the augmented intestinal absorption of glucose. INH has also been implicated in causing hyperglycemia by blocking specific steps of the Krebs cycle, which requires NAD. And also it stimulates the glucagon secretion. That's also one of the mechanisms which has been thought of by which it can cause hyperglycemia. There have been some case reports where after stoppage of isoniazid, the glucose levels have returned to normal. Even para-aminosalicylic acid and ethionamide, which are used in drug-resistant tuberculosis, can cause some abnormalities of the thyroid hormones, can reduce the thyroid levels and lead to hypothyroidism, can cause goiter. They also can reduce the systemic blood flow of thyroxine-binding protein, and they can reduce the thyroid content of the blood. So to summarize, tuberculosis can involve many endocrine organs, almost all systems of the body. Adrenal gland involvement is one of the most common involvement. If a patient has come to us who has been diagnosed as tuberculosis, and we are going to start rifampicin, it's justified to check one cortisol level because they may be having a borderline adrenal insufficiency and the adrenal crisis may be precipitated after starting rifampicin. Manifestation of these organs may be after years of the initial infection, so we should never forget to take the past history. Hyperglycemia should be adequately controlled because that leads to the faster control of the infection. Spread to the other organs is mostly by hematogenous route. Lymph node spread is also known. Multiple localization of the active specific processes is to be done because there can be multi-organ involvement. It may not be one. it's a great mimicker. So we may not just be stopping at one organ. We have to search if there is any other place where the affection is there or where else the involvement is there. The treatment is of the hormonal abnormality. That means the organ which is involved, suppose it's thyroid or adrenal, it is involved. We have to treat it. If the glucose values are high, we have to give insulin or accordingly the treatment. And also not to forget, we have to see that the tuberculosis is treated, because only then we can have a respite, or the patient's hormonal abnormalities can become better, or some patients, if they have an irreversible destruction, it may not recover at all. So with this, I think I end.
Thank you, Dr. Kalra. I think that was a very comprehensive presentation, mentioning telling us about the endocrinal manifestations of tuberculosis. As have been said, you see, most of the endocrinal manifestations occur because of direct involvement of an organ, you see, and because tuberculosis can involve almost any organ in the body, including the endocrinal organs. See. So most commonly being, of course, the adrenal gland, and then all other organs, thyroid, hyperthyroid, and pituitary, etc., can be involved and present with different manifestations, as have been said. I was also very intrigued to know that sometimes diabetes, you see, tuberculosis can also cause diabetes. It is known to, of course, aggravate any pre-existing systemic or other disease, you see, but I'm sure that it can be the diabetes being again a common problem, and otherwise tuberculosis, of course, occurs very frequently, 2 to 5 times more commonly in diabetics, and it also presents interferes with the clinical features, severity of diabetes control, as well as, and then of course the treatment as well. The anti-tubercular drugs can also cause problems and endocrinal alterations, as have been listed. So I think it will be better if we really ask the questions from the audience, and then try to answer some of these issues, or discuss some of these issues. Are there any?
Yes, sir. There is a question from Dr. Siban, who wants to know, okay, how do you manage hypercalcemia due to 125 hydroxyvitamin D in a patient with active tuberculosis? Sorry, that's from Likita Reddy.
Yeah. So good. Yeah. So should I answer?
Yeah, please, Pramila.
Yeah.
Yeah. So we have to see, first of all, we have to always remember that whenever tuberculosis causes any of the abnormalities, like whenever the patient has any abnormality secondary to tuberculosis, first of all, we have to just first treat the tuberculosis. That is the first important thing. Mostly after the treatment of the tuberculosis, most of these abnormalities can be treated. But when you have a patient who has come with hypercalcemia, so first of all, we have to see that we start the patient on anti-tubercular treatment. We have to see that the treatment is continued. We have to obviously manage hypercalcemia by doing rehydration, and all those things have to be done. And alongside with that, we can use steroids under the cover of anti-tubercular treatment. So this is how we have to manage. So basically it has to be managed with the treatment of the disease and hydration, and along with that, steroids can be given under the cover of ATT.
Okay. Thanks.
I must also add, you see, before we proceed further, that nowadays the treatment of tuberculosis has been slightly altered, you see. For example, although the intensive phase is given with the 4 drugs for 2 months, the maintenance phase now consists of generally 3 drugs, rather than 2 drugs, which were used earlier. So we use all INH, rifampicin, and ethambutol, see, and generally for 4 more months. So the standard treatment is for 6 months, total of 6 months, and that includes all forms of tuberculosis, except of course CNS and some cardiac or maybe even spinal tuberculosis, etc. But I suppose endocrinal tuberculosis, the duration would remain the same, but the number of drugs in the maintenance phase has been increased, you see. This largely to prevent the emergence of resistance, etc., etc. Yes, thank you.
Still the audience comes up with more questions. Chitra, could we have the answers of the quiz? So that, and
Most
then
interesting.
after that, we can take up the questions. Chitra's questions were absolutely mind-boggling. It took me some time to read them, first of all. So please, Chitra, if we can have your answers.
Thank you, Dr. Shaila. With your permission, I'd like to share the PPT this time with the answer slides with it. So the first question was this: a patient who's been started on treatment comes on the 5th day with blood pressure of 86/50 and tachycardia. So what's the first test you would order and with a low sodium? And what treatment would you give, and what's the diagnosis and mechanism? Almost all participants have got the first two questions right. Send a random cortisol as soon as possible and initiate treatment with IV hydrocortisone. Probably diagnosis for this visit is Addisonian crisis due to tuberculosis, but the question that it could be induced by ATT, which is rifampicin, which is an enzyme inducer, was the answer which was missing by both most contestants, and most people have scored 2 out of 3 for this. The second question: in individuals with tubercular meningitis, the most common abnormality of the pituitary is reported as, and this question is from a paper which was published from India in Pituitary 2010, which took a look at pituitary abnormalities in individuals who had TB meningitis, and this paper reported hyperprolactinemia is the most common pituitary abnormality to be found, followed closely by 42% of individuals showing relative or absolute cortisol insufficiency. So I'm going by this paper, and hyperprolactinemia is the answer that we're accepting. And this image, there are 2 black arrows. Some of them have missed the second black arrow. It's bilateral adrenal enlargement, and tuberculosis is one of the differentials in this context, as are numerous fungal infections due to histoplasmosis or coccidioidomycosis, and also not uncommon to see adrenal hemorrhages due to numerous causes, be it septicemia due to meningococcal infections or anticoagulant use. So any of this is accepted as an answer. The author is Jane Austen. It is believed that she had tuberculosis, probably Addison's disease, secondary to tuberculosis, and she does note that her color changed over many years, and she died. She wrote prolifically. The last book that she wrote was Persuasion, and many of her letters have also been published. So she lived in the time between 1775 to 1819, a window where anti-tubercular medications was not available. The next question is a person who's been on tubercular medication for 2 months now and comes with menorrhagia and pain and cramp. And what is the test that you should think of? She's complained with menorrhagia and pain and cramps. The answer is TSH. Rifampicin, which is enzyme inducer again, can sometimes increase the requirement of levothyroxine for individuals who have been on levothyroxine, but can also very rarely precipitate hypothyroidism in individuals who are susceptible, especially if they have a family history. And there are numerous case reports towards this end, and this is something to be kept in mind if they present with features of hypothyroidism. The next question: causes of hyponatremia, which is very common in individuals with tuberculosis, especially in inpatients, can be due to all of these, except the answer is diabetes insipidus. Diabetes insipidus occurs very, very rarely in the context of tuberculosis and does not lead to hyponatremia, at least. Hypercalcemia in tuberculosis is quite common, and the answer which is correct or which is not true in this situation is in secondary hyperparathyroidism due to vitamin D deficiency, you're likely to find hypocalcemia but not hypercalcemia. So the diagnosis in this image, this is again a published case report, is tuberculosis of the thyroid gland, which presented as a nodule. And this is a follow-up photograph of the same patient, and she received just anti-tubercular treatment and it resolved completely. So there was no surgery done and there was no steroid used in this context. There are numerous case reports of how cold abscess or tuberculosis of the thyroid gland resolves with just anti-tubercular therapy. Maybe caution for us to have conservative management top of line. The poet here who died to tuberculosis is John Keats, again in the same era as Jane Austen. Tuberculosis took away numerous artists, poets in this era. So he is one of the person, but his description of tuberculosis is probably one of the earliest documented evidence of how tuberculosis pans out. And this was at the time when they were still wondering if it was the weather that caused tuberculosis and some other things. The Bali Declaration was, as many of you have identified, is for the co-pandemic epidemics of tuberculosis and diabetes between the World Health Organization and the International Union Against Tuberculosis and Lung Disease. Probably one of the most important point which was spoken about in this was that to use the existing mechanisms to collaborate to screen for tuberculosis in individuals with diabetes more easily, and also to screen for diabetes in individuals with tuberculosis, as Professor Jindal and Professor Pramila Kalra have highlighted. That is to break the boundaries between the systems which are already in place for tuberculosis management and diabetes management. So that's the end of the quiz, and I'm going to stop sharing screen with Dr. Shaila's permission and Professor Jindal's permission. Can I announce the winners?
Please go ahead, Chitra.
All right. So we'll start with the first place. The first place goes to Shruti. She got almost all of the questions right, except probably the mechanism of crisis in the first patient and one of the key points for the Bali Declaration. So she's our winner of the quiz with 8 2/3 points. The second place is a tie between Dr. Guru Raj Rao from Karnataka. I'm not sure if panelists are allowed to enter the quiz, but he was the first to send it in, and I checked with Saptarshi. He said Dr. Guru Raj Rao has to win because he sent it in 5 seconds after we closed the quiz. And followed with Dr. Sibin. He's also in tie for the second position with Dr. Guru Raj Rao. And the third place goes to Dr. Moman Chattopadhyay. So those are the winners of today's quiz. Thank you so much for participating. Thank you, Endocrine Society of India, for the honor. Handing over back to Professor Jindal and Dr. Shaila to the deliberations.
Yes, thank you very much. And I must congratulate the winners, you see. So before I hand over to Dr. Shaila, I must also, I like to make one point regarding the tuberculosis of the endocrine glands, you see. The major problem which we, as well as I'm sure all the endocrinologists and internists face regarding the diagnosis of tuberculosis of all extrapulmonary organs, you see, because the diagnosis is most often made on morphological grounds, because of, for example, of Addison's disease from clinical history and CT scan. Same is true for pituitary gland and so on, you see. Although in pulmonary medicine, it is commonly believed or stressed upon that before the treatment, one must make a microbiological diagnosis. So that is the difficulty with most extrapulmonary forms of tuberculosis, which is present there. So attempts should be made to obtain the cytohistopathological or microbiological diagnosis, because otherwise nowadays we know that many other diseases can present with the similar morphological features, you see. Anyway, I think that was just by the way. Otherwise, I'm sure tuberculosis, as we know, and the most common cause, for example, of Addison's disease would be tuberculosis. You have to exclude other causes, but that can be done perhaps on the basis of clinical, radiological, and other criteria. Well, thank you.
Thank you, sir. Thank you for your insight. Before we call it a day, there is one more question from the audience, Pramila. And we want to know, I mean, Dr. Vichika wants to know, what is the role of metformin in diabetes management in a tuberculosis patient?
Yeah, very, very interesting question, actually, I would say, because we can put it other way around. Your role of now there is a role of metformin in tuberculosis management as well. There are some studies for that as well. Coming to the first question, which is the general question, that role of metformin in diabetes management, I would say if a patient has no contraindication to the use of metformin and patient is not acutely ill, there is no problem in continuing it. Most of our tubercular patients may be acutely ill initially. We might like to give them insulin. Yes, we do continue metformin over a period of time, because initially with rifampicin and all, they may present with nausea, vomiting, may not be able to tolerate oral drugs. So that point of time, we give insulin. Later on, we do add. But there is another point of view in that metformin has been actually found to reduce the intracellular growth of mycobacterium in AMPK dependent manner. And it has been actually found to reduce the chronic inflammation in tuberculosis. And there are some small studies for that it enhances the immune response. So they are actually studying metformin as a adjunctive therapy for improving the treatment of tuberculosis and the results, especially the pulmonary outcome and the reduction in the inflammation. So that way also metformin is a good drug. So both ways, I think we can continue unless there's an acute stage where the patient is not able to eat and we have to give insulin. So we do give insulin, but along with that, we can give it because it will help that way also.
I think that was a very comprehensive answer, and I'm sure it's completely answered Dr. Vichika's query. If there are any other, in any other queries, even from the panel members, Dr. Gururaja Rao, you can also put in your queries. First of all, a big congratulations.
Yeah.
And a big congratulations to Shruti also. And if there are no further comments, should we call it a day then? Saptarshi?
Thank you, ma'am. Thank you, Dr. Jindal. Thank you, Dr. Pramila Kalra, for an excellent presentation. And obviously, the questions asked by Dr. Chitra, they were both clinically as well as historically, as well as social implications. Everything was covered. So it was enlightening for everybody who participated. And a very warm thanks from Endocrine Society of India for joining in this program. We look forward to meet you again on next Sunday at the same time.